Anterior cruciate ligament (ACL) injury is one of the most common and significant knee injuries, affecting athletes and physically active individuals worldwide. The ACL is a crucial ligament located in the center of the knee joint, connecting the femur thigh bone to the tibia shin bone. It plays a vital role in stabilizing the knee by preventing excessive forward movement of the tibia and controlling rotational forces. Injuries to the ACL often occur due to sudden changes in direction, pivoting, landing improperly from a jump, or direct contact, making them prevalent in sports such as soccer, basketball, football, skiing, and gymnastics. An ACL tear can significantly impact knee function, leading to pain, instability, and long-term joint damage if not properly managed. ACL injuries are classified based on severity. A Grade 1 sprain occurs when the ligament is stretched but remains intact, causing mild instability and discomfort. A Grade 2 injury is a partial tear, where the ligament fibers are significantly damaged but not completely ruptured. A Grade 3 injury is a complete rupture of the ACL, leading to severe instability and loss of knee function. Complete tears are the most common form of ACL injury and typically require surgical intervention for full recovery, especially in active individuals. The mechanisms of ACL injury vary, but the majority occur through non-contact movements. The most common non-contact mechanism involves sudden deceleration, combined with a rapid change in direction or pivoting, while the foot is planted on the ground. This movement places excessive stress on the ACL, causing it to tear. Jumping and landing incorrectly, particularly with the knee in a valgus inward position, also increases the risk of ACL rupture. Contact injuries, although less frequent, occur when a direct blow to the knee forces it into hyperextension or extreme rotation, commonly seen in football or rugby. Several risk factors contribute to ACL injuries, including anatomical, biomechanical, and hormonal influences. Females are at a higher risk compared to males due to differences in knee alignment, ligament laxity, and neuromuscular control. Women typically have a wider pelvis, leading to increased knee valgus angles during movement, which places greater stress on the ACL. Additionally, hormonal fluctuations, particularly during the menstrual cycle, may affect ligament strength and elasticity. Poor neuromuscular control, weak hamstrings, and imbalanced quadriceps activation further increase susceptibility to ACL injuries. Other factors, such as previous knee injuries, improper training techniques, and playing on artificial turf, can also contribute to ACL rupture. Symptoms of an ACL injury typically occur immediately at the time of injury. Many individuals report hearing or feeling a pop in the knee, followed by intense pain and rapid swelling due to internal bleeding hemarthrosis. The knee often feels unstable, making it difficult to bear weight or continue activity. Reduced range of motion and stiffness develop quickly as swelling increases. In cases of complete ACL rupture, individuals may experience a sensation of the knee giving out or buckling during walking or pivoting motions. Without proper stabilization, continued instability can lead to further damage, including meniscus tears and cartilage deterioration, increasing the risk of osteoarthritis. Diagnosis of an ACL injury involves a combination of clinical examination and imaging studies. A healthcare provider typically performs specific tests, such as the Lachman test, anterior drawer test, and pivot shift tests to assess ligament integrity and knee stability. The Lachman test is considered the most sensitive for detecting ACL tears, as it evaluates anterior translation of the tibia relative to the femur. Magnetic resonance imaging (MRI) is the gold standard for confirming ACL injuries, providing detailed visualization of the ligament, meniscus, and surrounding structures. X-rays are usually performed to rule out associated fractures or bone injuries, particularly in cases of high-impact trauma. Treatment for an ACL injury depends on the severity of the tear, the patient's activity level, and long-term functional goals. Conservative management may be suitable for individuals with partial ACL tears, minimal instability, or a lower demand for high-impact activities. This approach includes physical therapy to strengthen the surrounding muscles, improve joint stability, and enhance neuromuscular control. Racing may provide additional support, allowing some individuals to continue daily activities with minimal discomfort. However, for those involved in sports or physically demanding activities, surgical reconstruction is often recommended to restore knee function and prevent recurrent instability. ACL reconstruction surgery is the most common surgical treatment for complete tears. As the ligament itself does not heal on its own, the procedure involves replacing the damaged ligament with a graft, which can be obtained from different sources. Autografts are taken from the patient's own tissues, typically the patellar tendon, hamstring tendon, or quadriceps tendon. Patellar tendon grafts are commonly used due to their strong fixation properties, but they may cause anterior knee pain postoperatively. Hamstring tendon grafts provide excellent flexibility, but require longer healing times. Quadriceps tendon grafts are another option, particularly for revision surgeries. Allografts, which are donor grafts, offer an alternative for patients who prefer to avoid additional tissue harvesting, but carry a slightly higher risk of rejection or delayed healing. The surgical procedure for ACL reconstruction is performed arthroscopically, using small incisions and a camera to guide the surgeon. The torn ACL is removed, and tunnels are drilled in the femur and tibia to anchor the new graft in place. The graft is then secured using screws or fixation devices, allowing it to integrate with the surrounding bone over time. Advances in surgical techniques, such as anatomic reconstruction and double bundle reconstruction, aim to restore the natural biomechanics of the ACL more effectively, improving long-term outcomes. Postoperative rehabilitation is crucial for successful recovery. Following ACL reconstruction, rehabilitation programs typically follow a phased approach, beginning with pain management, swelling reduction, and gentle range of motion exercises. Early weight-bearing is encouraged to promote healing, while bracing may be used for additional support. Strengthening exercises progressively target the quadriceps, hamstrings, and hip muscles to restore knee stability. Neuromuscular training, including balance and proprioception exercises, is essential to retrain movement patterns and prevent re-injury. Return to sports is gradual and usually takes 6 to 12 months, depending on the individual's progress and functional readiness. Functional testing, such as hop tests and agility drills, helps determine whether an athlete is prepared for safe return to activity. Long-term prognosis following ACL injury and reconstruction varies, depending on factors such as adherence to rehabilitation, graft choice, and the presence of additional knee injuries. While many individuals regain full function and return to sports, there is a risk of developing osteoarthritis due to cartilage damage and altered knee mechanics. Some patients experience persistent knee instability or graft failure, necessitating revision surgery. Preventive measures, including neuromuscular training programs, proper landing techniques, and strength conditioning, can reduce the risk of future ACL injuries. Preventing ACL injuries is a key focus in sports medicine, with injury prevention programs designed to improve strength, flexibility, and movement mechanics. Programs such as the FIFA 11 and PEP prevent injury and enhance performance, emphasize neuromuscular control, landing mechanics, and agility drills to reduce ACL injury rates. Strengthening the hamstrings, glutes, and core muscles helps counteract quadriceps dominance, which is a common risk factor in ACL injuries. Proper warm-ups and dynamic stretching before physical activity enhance muscle readiness, while avoiding risky movements, such as landing with excessive knee valgus, can further protect the ACL. Emerging treatments and research in ACL injury management continue to advance, including biologic augmentation techniques, tissue engineering, and regenerative medicine. Platelet-rich plasma (PRP) injections and stem cell therapy are being explored for their potential to enhance graft healing and reduce recovery time. Additionally, advances in imaging technology, such as three-dimensional MRI, provide more accurate assessments of ACL integrity and surgical outcomes. ACL injury is a significant knee condition that requires careful diagnosis, treatment, and rehabilitation to restore knee function and prevent long-term complications. While conservative management may be effective for some individuals, surgical reconstruction is often necessary for athletes and active individuals seeking to regain full mobility. Rehabilitation plays a vital role in recovery and injury. Prevention strategies can help reduce the risk of ACL tears. Ongoing research and advancements in surgical techniques continue to improve outcomes, offering hope for better long-term joint health and functional recovery.